Yeah, fall back too close, you ain't even know me. Trust my word is from way back from the north. Stay in the order.
And so how do we treat these patients? How do we decide if they need to be on medicine? It's really based on symptom severity and symptom frequency. And so our current guidelines are if this is happening repetitively. So if there's been more than 3 episodes of cough and wheeze and difficulty typically associated with a virus, especially if it's landing them in the hospital or requiring, trips to the emergency room or urgent care. And especially if we do feel like there's physician diagnosed wheezing, if there's abnormal exams, but this is once again happening over and over, then those are kids that would benefit likely from at least a trial of inhaled steroids. When I started talking about what's underlying, when we talked about the definition, I think there was an important word that was in that definition, and that's inflammation. Now, whether that inflammation, which really just means swelling of the airway, whether that inflammation is being driven by virus, whether it's being driven by allergy, whether it's being driven by air quality, temperature, whatever that trigger is, inflammation, as we understand it, is really at the core, the underlying sort of bedrock, if you will, of asthma. And so treating that inflammation is a really important part of what we do when we're trying to take care of asthma. Now, I think it's important to recognize that our decision about what medicines we choose and how often we give them really comes with an open discussion with the parents, right? And so there's not just one way to treat, especially in this population, especially in these younger populations, but really as we go through all these different types of asthma, I think recognizing that this really should be an open discussion between you and your physician, right? The idea that this should be what we call shared decision making, so that it is a treatment plan that you feel comfortable with, but also a treatment plan that the physician feels comfortable with, based on their assessment of the severity and what's going on. So it really should be a kind of a synergy, a synthesis, if you will, of both the physician coming with information and understanding, but also the parent understanding, appreciating, understanding what's going on, and then making a decision together about the best treatment plan. And so when we think about this group of kids, there really are a couple of different options. One of the things, especially if symptoms are not that frequent, it's happened repetitively, right? This has happened at least 3 times in the past season, or at least in the season maybe even that you're in currently. One of the options that we have available would be to use an inhaled steroid. So the idea is that we're going to use a medicine to help with inflammation, but this is just a medicine that we're inhaling in really small doses, microgram doses. But we're going to do this at the first sign of an illness. So instead of doing it all the time, which has really been sort of the typical approach that we take with asthma, and we'll talk about that, with other treatment plans. But in this, since these children are still young, we're still working through the diagnosis, and the symptoms are not happening that often, the approach is to use the inhaled steroid. Usually we'll use a little bit of a higher dose, but we'll do it at the very first sign of that viral illness and continue through for the duration of the illness. And so this kind of as needed use of inhaled steroid is nice because it's less steroid exposure, but it's not easy, right? You've got to be really paying attention because these inhaled medicines, they take a couple of days or sometimes a week to really kind of hit their stride, to really become effective. And so you need to be on it. You need that first sign of the runny nose, the first sign of any of those symptoms, you need to be starting that inhaled medicine. And importantly, technique is very important. And this really goes across the board, and I'm probably going to say this several times over the course of these different posts. These medicines, especially the daily medicines or the preventative medicines, even if we're just doing them episodically, they're low dose. These are topical medicines. One of the analogies I'll use is it's like putting an ointment on a rash. It's just that the airway, which is the largest internal organ, that's where the rash is. That's where the inflammation is that we're trying to address. And we're trying to take these microgram doses of medicines and put them on that rash, on that airway. And when we're talking about someone who's 2 or 3 or 4 years old, it's kind of an art. It's not easy to do. And so often we'll either use a nebulizer or we'll use an inhaler, but we'll do it with an air chamber or a spacer. And we need the child to be cooperative. And that's really the most important part of all of this. They need to be breathing calmly. They need to be breathing gently so that we can get this medicine, these very small particles, past the throat, past the mouth and the oropharynx and into at least the central airways, so that then they can passively diffuse into those smaller airways. So if they're screaming, if they're losing their mind, if it seems like you're doing some kind of torture to them, you're not effectively delivering the medicine. And so that's probably the biggest challenge that we have when we're trying to do this with nebulizers, is you're holding them down for 7 minutes, 6 minutes, depends on how new or how old your nebulizer is, and that mask has to be on their face the whole time. And so unless they've really grown up with that nebulizer, or unless they're really very distractible, they're not going to sit there. You're going to have to chase them around with the mask, or they're going to be screaming their head off. And sometimes I've heard it said, well, if they're screaming, they're inhaling, and that's not true. Yes, it's true they're inhaling, but the airflow that they're with those ragged breaths, it's so turbulent, the medicine just slams the back of the throat and gets swallowed. And remember, we're trying to treat the airways. And so if we don't get the ointment on the rash, we're not going to get the treatment that we're trying to get. And so we want that nice, calm breathing. And so with our inhalers, we're going to do it with a spacer, and we're going to just need to get 4 or 5 just nice, calm breaths. I think the other important thing is it needs to be sometime in the morning, usually if we're doing it every day, or even if we're doing it on that as needed basis. They're usually done twice a day, sometime in the morning and sometime in the afternoon. The timing of that is also going to depend on the child. So if they get up and they're grumpy and they're not going to cooperate, then you wait until they've had breakfast, until they, whatever it is, that's making them grumpy, until they're in a good mood. So if that's later in the morning, that's okay, because technique and cooperation is way more important than it being at a specific time. And the same thing goes for the evening. If it's later afternoon, not even really into the evening hours, but that's when they're the most cooperative. And when they get into the evening hours, they kind of turn into little monsters, then that's not going to be the time to do it, right? So technique is so important. And so in this one treatment plan, like I said, we can use the inhaled steroids, sometimes at a little bit of a higher dose, but we're going to do it at the first sign of the illness and continue for the duration of the illness. And then we follow response. That's the most important part. We want to see, does the child do better? And by that we mean, wow, after we've started this treatment plan, while we're on it, they get sick, right? We know we can't keep them from getting sick, right? Unless you move to the moon or go live in Alaska away from any other children, they're gonna get sick. But do they handle it better, right? Do they get sick now for a few days or a week, and there's not the labor breathing? You're not up with them all night. There's not that sense of urgency. You're not having to take them to the emergency room or into the pediatrician. And most importantly, they're not needing those systemic steroids, the prednisone, the dexamethasone. They're not getting those huge nuclear bombs of steroids. And so if they're able to get sick and they handle it, and it's short term and it's easy, and you're not worried, right? That's one of my things I always ask, is mom worried? Is dad worried? And if they're not worried, then the medicine is working. Ideally too, because the duration of the symptoms are so short, how often they seem to be getting sick becomes less often. Now, we're not changing how often they're getting exposed to virus, but their response to that virus and the duration and severity of symptoms becomes less. And so now it seems like it becomes less frequent. And so that's important. And of course, we only want to be on a medicine if we're seeing an improvement. The use of the inhaled steroids, whether it's episodically or whether it's every day, morning and night, is effective, but not 100% effective. And so some kids are not what we call steroid responsive. And then once again, if they're also not responding, that's when we have to take a step back and think about some of those other things I mentioned that may be going on, that may be mimicking our asthma. The other approach, now if these kids are really severe, if these are kids that are in the hospital frequently, if these are kids that really, they're only without symptoms for a few days at a time or for very short periods, then that's the kids that we're probably going to recommend, let's do these inhaled steroids every day. We're going to be chasing our tail if we're trying to do them just as needed, and it's going to be much more effective. And that really is the way that they're best studied. But once again, we're making that decision in conjunction with the parents and based on this, how bad the symptoms are or how often the symptoms are happening. I think understanding the safety, though, of the inhaled steroids compared to episodes of systemic steroids. So when we have an asthma attack or exacerbation, if you end up in the ER or if you end up in the hospital and you end up on prednisone, you end up on dexamethasone, a 3 to 5 day course of those systemic steroids is like being on these inhaled medicines for 3 to 5 years. So the inhaled medicines are dramatically lower dose, a dramatically lower systemic steroid exposure than being on those systemic steroids. Sometimes I say it's like a nuclear bomb compared to a very small firecracker. And so of course we want the symptoms to be under control. We want to minimize risk, but we also want to minimize side effects and be on the least amount of medicines that we need to be on.
Yeah, fall back too close, you ain't even know me. Trust my word is wrong, way back from the know. Stay in the order.